given by Dr. Mastracci, who is going to be talking to us about surgical smoke. So, Dr. Mastracci, if you want to take control and bring up your slides, we'll turn the show over to you.
Thank you, Dr. Pat. Let's see, how does this look for you guys? Good?
Yep, we can see it.
Perfect. My name is Julia Mastracci. I'm a PGY2, and I'm going to be talking with you all about surgical smoke. No disclosures. This is a brief outline of my presentation, starting with a case example. MB, this is a 34-year-old male status post, MBC 7 months prior with T8 and T9 compression fractures that were thus far treated in a TLSO brace. He has 10 out of 10 back pain, as well as a kyphotic deformity noted across his compression fractures. And the plan for him was a T5 to L1 posterior instrumentation and fusion. Cases like MBs and other spine cases that required large exposures with electrocautery got me thinking about surgical smoke and our exposure and the risks and what we may be able to do to mitigate these risks. Starting with the history of surgical smoke, in 1931, a patent was issued to William Bovie. He was a physicist at Harvard, and this was for what we think of now as a monopolar circuit, Bovie type device. It was first used by a neurosurgeon in Boston, Dr. William Cushing, and it's reported that he wanted the device to achieve better hemostasis when he was resecting brain tumors. Mr. Bovie eventually sold the patent rights to this device for $1, and it is reported that he actually had financial difficulties later in life. The circuits of electrosurgery, starting out with a definition. Electrosurgery is the process of cutting or coagulating using an electrical circuit, and we can do this through both a monopolar circuit and through a bipolar circuit. The monopolar circuit is what we think of with a Bovie device, and it's where the electricity is started through a generator. It then moves through an active electrode, which is what we think of as the Bovie device, the actual device we're using for cutting and coagulation. It then moves to the patient and then leaves the patient through a return electrode. In a bipolar circuit, the two tines of the forceps act as the active electrode and as the return electrode. So only the tissue that is in between the two forceps actually has electricity passing through it. And there is no electricity moving through the rest of the patient and no return electrode is needed. So moving on to surgical smoke and the exposure we have to it. It is estimated that 500,000 nurses, technicians, and physicians are exposed to surgical smoke each year. And it is thought that OR personnel who are working in the operating room every day probably have higher rates of exposure versus a surgeon who may be in the operating room 2 to 3 days per week. It is known that perioperative nurses have higher rates of upper respiratory illnesses when compared to the general population. In regards to the size and contents of surgical smoke, 77% of surgical smoke is less than 1.1 micrometer. And just for reference, 1 millimeter is equal to 1,000 micrometers. The mean size of surgical smoke is 0.7 micrometers. However, what we're using a lot, the Bovie electrocautery, is actually less than that, 0.7 micrometers. And the size of the particles helps determine where the particles land and how far they can travel. So for example, particles greater than or equal to 5 micrometers can land in our oropharyngeal walls, versus smaller particles can travel farther and make their way all the way into our lung tissue. We know that surgical smoke is hazardous. This statement by the CDC states that the smoke plume can contain toxic gases and vapors, as well as dead and live cellular material, including blood fragments and viruses. It also states that the surgical smoke has a mutagenic potential. Furthermore, in regard to the content of surgical smoke, it is 95% water and steam and 5% debris in the form of particulate matter. Furthermore, the debris itself, as stated in the CDC statement, is dead and living cellular material, blood fragments, bacteria, viruses, toxic gases, and vapors. The content of the smoke also depends on the type of device we're using, as well as the tissue that we are working on. So for example, electrocautery is abundant in hydrocarbons, nitriles, fatty acids, and phenols. And adipose tissue, for example, coagulation of that results in production of aldehydes. We know that surgical smoke also contains viruses, bacteria, and possibly malignant cells. Viral DNA has been identified in surgical smoke, and we know that surgeons who use lasers to treat lesions caused by human papillomavirus have higher risks of lesions caused by HPV. There are also studies that show that bacteria has been found on distant operating room surfaces after the use of electrosurgery. In one study that looked at the bovying of melanoma in mice, there were viable melanoma cells found in the surgical smoke. However, there is no current data in humans that cancer or malignant cells can be transferred during surgery. In regards to the mutagenicity of surgical smoke, this is a list of components in surgical smoke. As you can see, many of them are carcinogenic, and a couple of them are also teratogenic. When we compare these components to cigarettes, 3 components, including acetaldehyde, benzene, and polyaromatics, are found both in surgical smoke and in cigarette smoke and are known carcinogens. It has been found that the amount of smoke condensation from 1 gram of electrocauterized tissue has a mutagenic potential of 3 to 6 cigarettes. In one study that kind of used this data and applied it to a plastic surgery OR for breast reduction surgery, it was thought that the amount of surgical smoke produced was equivalent to 27 to 30 cigarettes. Looking further into this study that sought to quantify how much mutagenicity there is in surgical smoke, they looked at a Bovie device and used it in a closed box for 60 seconds. They then collected all of the smoke particles and ran them through a mutation assay. And the way this mutation assay works is you have a known strain of Salmonella that has a known hotspot mutation that basically acts as a spot for new mutations to come. And if these new mutations come and affect the Salmonella strain grows faster. So on your plate, if your Salmonella is growing faster than standard, then you know that what you added to it. So in this case, the surgical smoke has a higher mutagenicity. They found that the mutagenicity of electrocautery smoke was 3,300 revertants per milligram per plate. And when you compare this to 1 cigarette smoke, it is 1,200 revertants per milligram per plate. They also found that when you cauterize 1 gram of tissue, it results in 40 milligrams of condensates versus 1 unfiltered cigarette results in 5 to 10 milligrams of condensates. So they therefore deduced that cauterizing 1 gram of tissue has a mutagenic potential of 3 to 6 unfiltered cigarettes. Moving on to the side effects of surgical smoke, we know that the smoke can cause headaches, eye, nose, and throat irritation, as well as acute and chronic pulmonary conditions. As mentioned earlier in the talk, perioperative nurses have 2 times the incidence of bronchitis, asthma, sinus infections, and allergies when compared to the general population. These perioperative nurses also have significantly higher rates of severe persistent asthma when we compare them to administrative nurses. There is no definitive evidence, however, that surgical smoke increases our risk of lung cancer. So what can we do to help manage surgical smoke now that we know the risks that are associated with it? We can think about minimizing the production of surgical smoke and just being aware of how much we're using electrocautery in these devices. We can also be aware of our operating room ventilation settings. The CDC mandates that our operating rooms perform a minimum of 15 air exchanges per hour and that our operating rooms maintain positive pressure, both of which we are doing here at Atrium. We can also think about what devices we're using to remove smoke. Factors that affect smoke removal through suction devices include direct factors such as the distance of the device from the smoke source, the power of the suction, the diameter of the tubing, and the amount of smoke produced. Indirect factors include personnel available, incision length, and attitudes of the surgical team. Smoke removal devices include a Yankauer suction tip, which I think a lot of us use, versus a wand or pencil, which is basically a 2-in-1 device that contains both the Bovie and the suction, and newer open cell foam technology. This study sought to compare how much smoke was produced when no suction was used versus a 2-in-1 smoke evacuation system. And they use one of these pen or pencil devices that has a bovie connected to suction. They looked at each of these devices in 15 thyroid surgeries, and they measured the smoke detected at the surgeon's mask. They found significantly less mean smoke level and maximum smoke level when suction was used. So what we can learn from this study is that definitely some sort of suction should be used to remove smoke from the operating room. This study sought to compare different types of smoke removal devices. So they compared a 2-in-1 smoke evacuator pencil. They used a Stryker Neptune pencil versus a cautery with a Yankauer suction held by an assistant, which is typically what I see happening in our operating rooms, versus cautery with no suction. And they use these devices in 30 pediatric tonsillectomy and adenoidectomy cases. Again, they measured the amount and the size of particles at the surgeon's mask. They found that the no suction group had a significantly higher particle concentration rate, but there was no difference between the 2-in-1 smoke evacuator system versus the suction by assistant. So I think how we can apply this to our operating rooms is if you do have an assistant who can use the Yankauer suction and consistently evacuate your smoke, it is a good option. However, if you don't have an assistant who is with you all the time and that may not be available, then consider using one of these 2-in-1 suction devices. And then finally, this study sought to examine this newer technology, which is a para-incisional evacuator. It is a open foam cell core device that runs continuous suction, and basically one side of it is sticky. So you just stick it down right next to the incision and it continuously suctions. They evaluated this device in 25 spine surgeries and compared it to 26 spine surgeries with a 2-in-1 smoke evacuation pencil. And they actually measured the smoke on the anesthesia side of the drape, so not exactly on the surgeon side of the drapes. They found that there was no significant difference between the para-incisional evacuator and the evacuation pencil in regards to average smoke level. However, in regard to peak smoke level, the para-incisional evacuator resulted in a 96% reduction versus 75% reduction in the evacuation pencil. So again, if you don't have an assistant available to help you and you're doing a lot of these surgeries on your own, consider using one of these devices that kind of works on its own, doesn't need an assistant, such as the para-incisional evacuator. We can also think about what evacuation systems we're using. Our options for evacuation include local exhaust ventilation and central smoke evacuation. From what I've learned talking with staff and OR personnel at Atrium, central smoke evacuation is not common. It's not present at Mercy or at Maine. It's very expensive. It's something that's only done in like brand new operating rooms. And basically what it does is it takes the suck or the smoke, it goes into something like the boom, like usually the boom, and then gets completely pumped out of the operating room. So what we're using mostly here at Atrium, at least at Mercy in Maine, are these local exhaust ventilation systems, such as the Neptune system, which is a closed system for fluid smoke and aerosol. And how I typically see this Neptune device used is through the quote unquote regular suction part, which is where we use a Yankauer suction to suck up both fluid and smoke. And it goes through the front of the Neptune in these little circle canisters. And when it goes through that, it's using a HEPA filter, which filters at 99% of particles size 0.3 micrometers. There is actually a separate smoke suction component of this Neptune that I don't see used frequently in our operating rooms. It's on the side of the Neptune. It's this little gray box. And what this requires is using some sort of suction different than the Yankauer that's collecting fluid, and the suction only collects smoke, and then it goes through a separate tubing through the side of the Neptune. And what this does is it runs the smoke through a higher level filter, a ULPA filter. This filter filters 99% of particles at 0.1 micrometers. So I've been told that the plastic surgery operating rooms at Maine are using this suction, the smoke suction option on the Neptune, particularly in breast reduction surgeries. So it seems like an option that would be available to us to help protect us and keep us safer. And then again, when we're thinking about what we're sucking up with the Yankauer suction going through the regular HEPA filter, it's filtering particles as small as 0.3 micrometers. But what we're producing with the Bovie and with electrocautery is likely smaller than that. We can also reduce our inhalation of smoke through masks. Surgical masks, when they are very tight to your face at the top and the bottom, filter particles greater than or equal to 5 micrometers. However, I think most of us wear the surgical mask a little looser than what is recommended, particularly at the bottom. So be aware that if you're wearing your surgical mask loosely, it is less effective. N95s filter particles 0.3 to 0.1 micrometer, and surgical helmets or hoods that we typically use during joint replacements are not approved as respiratory PPE. We can also promote awareness, communicate openly about the dangers of surgical smoke, and just create an environment and an atmosphere in our operating rooms where people feel safe to speak up and talk about this topic. In regards to future directions, multiple states have started passing legislations that require smoke-free operating rooms. The states that currently have passed such legislation include Rhode Island, Colorado, Kentucky, Oregon, and Illinois. And in 2022, bills for Washington, Utah, and Arizona have been advanced. No such legislation exists in North Carolina, so no hospital in North Carolina or South Carolina, including our atrium hospitals, are legally required to be smoke-free. An example of what this legislation entails, this bill from Illinois states that hospitals are required to, quote, adopt policies to ensure elimination of surgical smoke plume by use of a surgical smoke evacuation system. The hospitals are then mandated to report to the Department of Public Health within 90 days after the Amendatory Act's effective date that policies have been adopted. So again, these laws don't exist currently for us, and we are not legally mandated to have a smoke-free operating room. However, it may be coming in the future. So in conclusion, we know that nurses, technicians, physicians, and patients are exposed to surgical smoke in the operating room. We know that this smoke is likely harmful and carcinogenic to our bodies. We have multiple management tools that we can utilize to minimize smoke production. We can also think about what we are doing to remove smoke and what devices we're using to remove smoke in our operating room, as well as the evacuation systems that we're using, including the regular suction with the combined liquid and the smoke versus a just smoke removal setting. We can also reduce our inhalation through the use of masks. And in regard to the future, I suspect that North Carolina will likely end up with some sort of legislation that requires our state as well as Atrium to have smoke-free operating rooms. These are my references. Thank you to Chase Spivey, Charles Morgan, and Shelby Carter with Stryker for helping me understand kind of what we have at Atrium and our options in our operating rooms. Thank you.
Thank you, Julie. That was a great talk. A lot of stuff we obviously see every day, but we don't necessarily think about. First question I'd have, and maybe you mentioned some of this and I just missed the detail, but I would assume that the biggest barrier for any hospital system is just cost. Any of these things, adding any of these items in is an additional cost. In your look at this, was that the biggest barrier to incorporation of this being financial, or were there other potential barriers?
So from what I learned from talking with people at Atrium, a barrier wasn't necessarily cost, but actually the contracts that we have in place. It seems like from what I've learned that there are quote unquote energy contracts that we have. So we contract with specific companies for our energy devices, which include these Bovie devices. So I think in that way, we're limited to what tools we legally have access to.
Interesting. Why don't you go ahead and stop sharing your screen? We can see if anybody has any questions.
Julia, I have a question for you. First of all, good talk. I agree with Josh and appreciate getting the information. Tell me again why the spacesuits don't work. Is the intake, does it not have a filter that would help with this? it seems like rather than buying all these other devices that we're already pretty versed in that, maybe that's a solution just to be more universal with those.
Yeah, so I did try to find out more information on the spacesuits. And it's almost like there's kind of like a hard stop from what I can find. Like Stryker and these companies that make these suits are, and these hoods are saying like, this is not PPE, it's not approved to be PPE. Like that's like legally what we have to say. I was able to find a couple of studies that examined these hoods in the setting of COVID-19. It seems like there was a lot of, thought then like, well, can we be using these hoods now that we have less PPE available? There was one study I could find that looked at the like N95s versus wearing a surgical hood. And it seemed like at higher particle concentrations that the hoods were working effectively and moving stuff out, but at lower particle concentrations, they weren't working effectively. And sometimes actually, since they're open in spots, the air and the particles can get trapped inside. So it seems like that could be a potential option in the future, but that literature just doesn't exist right now.
Is Brad's hand up, or is that?
No, I don't think so.
No.
Colin, you have a comment?
Yeah, I was just going to say, I looked into this a little bit at Maine last year, and we do have two products that are available. There is the one that I think Julia showed in her presentation that looks like a Bovie with an extendable tip, and the suction goes over it. It's built into it. That is a more expensive device. The one that I've been using for cost-saving purposes is this one that is literally a piece of plastic that clips over a regular Bovie and has a suction hose attached to it. I can't imagine it costs much at all because it's just plastic, but I've been using that for about a year. Sometimes it's a little finicky and gets loose, but for the most part, I think it's done a great job of evacuating smoke for me when I don't have somebody else available or there's not enough hands to hold the regular suction. So I'm not sure if that's available at Maine, but it's worth asking the question. Or at Mercy, I mean.
Yeah, I've had a little experience using that one that has the combined suction Bovie. I find that the tip of it just becomes kind of cumbersome, and specifically to get into tight areas, it's not very user friendly. Any of the other folks listening, have they asked for things and had people say no to them, or have we tried to find solutions for folks?
I know Josh, can you hear me okay?
Oh, go ahead. Yeah, Bates, go ahead.
Yeah, I've used the ones that we have now that have the evacuator built in, but like you said, you do have that challenge where it can be hard to get into smaller areas, especially if you're trying to use like the equivalent of the extended Bovie tip. And once or twice I've seen a different product, I really don't remember the brand name, where instead of the entire smoke evacuator moving with the tip of the Bovie, just the tip itself moves. Now, of course, you have your evacuation device a little bit further from where the smoke is being generated, but it still allows you to use the Bovie in places where you need a little bit just smaller device, a little bit more precision, and it's still better than having an assistant. So I think there are just different variations of the product which make it easier to still have smoke evacuation, but yet be able to use the Bovie in those tighter areas. I've had some trouble when I did request that. It was reported as a contractual issue, but hopefully that's something that will change in the coming months.
Another quick question.
Erica, go ahead.
Another quick question about the bipolar versus the Bovie. I may have missed that. Was there any major difference between using the bipolar?
No, I couldn't find any studies that parsed out the difference between the bipolar and the Bovie and the amount of smoke produced.
Masanis, I see your hand up. Is that hopefully intentionally?
Yes, it's intentional. One question I have, speaking back to Dr. Mormon's comment, I'm just wondering if moving forward as an action item, it makes a lot of sense to have the filter in the isolation suit, since we have I would say there's a good percentage of surgeries that currently use them. And so who would be our contact point within Atrium for that?
It may be the Stryker folks if they make the suits, John. They may be the best conduit for figuring out what.
Yeah, I agree. Okay, we can, yeah, Mercy, I'll certainly inquire about this, probably tomorrow. But I think that might be a good first step, at least for some of the cases.
I will also take the YouTube feed for this talk and share it with Monica and some of the other OR folks to sort of let them know what at least we're discussing and talking about, and let them understand the concept. Julia, one last question I had. So you had mentioned, just using the Yankauer suction to sort of suck the smoke. So based on particle size, are we really sucking up as much as we think, or is it just the colorful, fluffy stuff that we see that we're actually smoking? Like, does that actually make enough of a difference to, use to suck that smoke?
I think it is, using the Yankauer does, from what the literature show, suck up the smoke. It's just a matter of the filters that it goes through. Like when it goes through a filter that's filtering both liquid and gas, it's filtering larger particles versus a filter that does just smoke has the capacity to filter a smaller particle.
Gotcha. Yeah, it reminded me of people who thought smoking cigarettes with filters would be way safer than the old unfiltered cigarettes. But it was more of a mental improvement than anything else. All right. Well, great. Thanks a lot. Really helpful and user-friendly talk. Maybe we can have some action from this. So thank you very much for your comments and information you provided us.